before the break, I will try to keep your attention still for a couple of minutes. Момчета, ще пуснете ли лаптоп от тук? So we will speak and show about something different and very new for Europe. So for a long time, the so-called orbital atherectomy was not available in Europe. And in your program, on the back, you are going to see that it's we are not in fact in the front. In the front, on the bottom right, you are going to see there is a hands-on session. It's one of the simulators that, thanks to Abbott, is here. So you can touch the new atherectomy system. In fact, it's one of the breakthrough for peripheral arterial disease, especially for calcium-containing lesions. And for probably 5 to 10 minutes, I will show you a case of a huge calcific burden, and it's a multiple restenosis case that you are going to see now on the digital subtraction, that multiple subtotal stenosis of the SFA. You see, it's a really very, very big calcific burden, and very challenging situation to be treated in this still smoking lady, 76 years, still smoking, and she continue insisting to smoke, not to stop smoking. And she had multiple stenting on the iliac level and multiple balloon interventions, successful balloon interventions on the level of the SFA, right SFA. So what are in fact the steps? It's in fact the most important to cross beyond the lesion. The most important to cross beyond the lesion. It's let's say that our friends from Abbott will not be let's say upset, but because at least part of the group here, we are cardiologists, so it's like a rod ablation, but it's better. Why is better? It's more stable. It's orbital atherectomy, so there is some eccentric movement. It's not just like the burn, and that is only rotating. The orbital atherectomy, how the name is saying, is orbital, so it's a little eccentric. It's going outside. It's going outside of the main axe. And this level of going outside the main axe is dependent on the rate of revolutions. So there are three levels. You see, you can observe in the meantime the critical stenosis on several levels. You see the stents into the iliac artery. There is also some edge restenosis of the iliac stents, but you are going to see what we have done. And with this orbital atherectomy, in fact, the idea in calcific lesions like this one, to overcome the huge resistance of the calcium, to make not only some atherectomy of the calcium, but mainly to change the compliance of the artery. In fact, removing part of the calcium and changing the compliance of the artery is improving much the results. It's in fact reducing the risk of dissection of the intimal dissection and the necessity of stent, and definitely it's facilitating our life. They are elaborating, it's from the kitchen of Abbott, they are elaborating now a system for recanalization. So after crossing with the wire, they are elaborating a system for recanalization of uncrossable lesions that are even not possible to cross by a balloon. Probably next year we are going to have in the armamentarium also this one, and it's really extremely stable. The other beauty of the orbital atherectomy is that in fact the abrasive part, the abrasive part of the burr, it's not burr, but it's like a burr, it's both in front and behind. So there is, in fact, atherectomy effect on both directions, in front and back. So in front and back there is a ablation of the surface of the calcium. And because of that, there is the second advantage. It's practically almost impossible this part, the bird, to be stacked, because it's removing part of the tissue of the calcium also on the back way, on the way back. So the possibility the bird to be stacked is very low, and it's possible to be applied both on the coronaries and peripheral intervention. And in this particular situation, you probably, in fact, we have used gladius wire in order to cross, something from the preparation. This is the preparation of the lubricant. In fact, in order to facilitate the rotation of the device, there is a lubricant that is, we are putting 2%, in fact 10 milliliters in 500 milliliters of saline. In Bulgaria, in the majority of cases, we have vials of 500 milliliters. In case it's 1 liter, it's possible to find somewhere in Bulgaria 1 liter, you have to put 20 milliliters of lubricant. And the lubricant, of course, like for the rotablation, it's important to facilitate the rotation, and not only the rotation, but also the movement between the system, between the console and the wire. So it's facilitating the loading, the rotation, and unloading of the system. So because of that, is the lubricant is performed all the procedure. So the first step, yeah, I'm showing here the system itself. It's coming all together. It's coming all together. In fact, the device and the burr. Next generation will be separated. So the console with the small knob and lever, the lever that is moving in fact forward and back the device is on the console, and the next generation will be separated console. So we can change the burr several times, to increase the burr several times without changing the console, but this will be next year. Now everything is coming together, the console, and the burr is one part of the console that is working console. So the most important is to cross predictably, to cross inside the true lumen in order to put a microcatheter, and inside the microcatheter to put the specialty wire that is utilized for the orbital atherectomy. There is a specialty wire. It's not possible to be performed on any wire, but there are 018 and 014 versions, and several sizes, 1.25, 1.5, and 2.0. Am I right? I'm right. Okay. So still remember something. And as I mentioned, it's good to go stepwise, not to jump directly to 2 millimeters, because it can be too aggressive and it's a little risky. In case of critical stenosis, for me, at least in our Balkan conditions, the big reason will be critical stenosis. In stenosis that don't need debulking and atherectomy, probably it's not so important, but in critical stenosis, it's advisable to start with the smallest one, with 1.25, and to increase the revolutions, to increase the rate in order to increase the orbital diameter, so to increase in fact the space that is ablated. It's ablated by this fastly rotating. There are 60,000 per minute, 90,000 per minute, and 120,000 per minute revolutions. And it's definitely one of the very important advice is to move slowly. Moving slowly, two reasons. First, to avoid dissection, to avoid trauma of the endothelium. And the second is to avoid big burden of embolization. So this is very important, to move slowly in order to allow, if a debris is separated, to go through the circulation without stopping, without clogging the distal circulation. And like shown here, this is, in fact, you see there is a green knob. This green knob is in fact on-off and blocking and releasing the movement. And of course, all the system has to be straightened very well after crossing with the wire. And after straightening everything, we start, in fact, the ablation. So the wire is already beyond the stenosis, and this is the position already, the burr proximally to this part that is with the critical lesions. There are in fact several. In fact, the tolerance is 15 centimeters. So from the starting position to the final position, there are 15 centimeters of treatment and 15 centimeters of moving the knob. And in fact, this can repeated many times, but in most of the cases, 2-3 times of repetition is sufficient, and we can move forward to go ahead if there is another target zone. Okay, you see how slowly it's moving, very slowly. So really, very slowly. You remember with the rotablation, there are some cases in which with the rotablation we're doing that is also a crazy idea. It's not a good idea to do it like this. But in this situation, definitely it's part of the instruction for use. Slowly. So this is crucial. This is very important. And there is some resistance when touching the critical part. There is some resistance, and when you touch the resistance, you can do several small moves behind and forward, step by step to make some ablation of the surface of the calcium in order to cross. And also it's important, again, for the microcirculation protection, is in case you have 25 seconds of intervention, 25 seconds session, you rest at least 25 seconds. So how long is the treatment? This is the break. So you have to break, to stop for at least 25 seconds. And this is, you see, we are already more distally to make intervention on the next critical portion of the SFA stenosis. And you see the proximal one is not anymore so critical like it was. And you see a critical stenosis down there in this segment. And as a next step, we went there. And we crossed several times with different speeds. Okay, we are more distally now. You see, slowly going there. It's really almost subtotal occlusion. When we crossed with the burr, when we crossed the distal critical stenosis, and the flow disappeared. It means that, in fact, the catheter of the system was bigger than the residual lumen. It was really a critical stenosis. And after crossing several times with 2 speeds, you see we are already distally. And after making also the distal treatment, we made a 4 millimeter balloon, long one. The lady, she was not only smoker but also diabetic, and the vessels of the lady were, the reference diameter of the vessel was not very big. And after making the ablation, we positioned the balloon, and we had used, of course, you see the indentation of the balloon still there, but it's very important. I will repeat once again. The idea is not to remove the calcium. It's not to clean the artery. The idea is to make the compliance of the artery different. And after putting the balloon for a long, prolonged inflation, in fact, we saw after the first ballooning, we saw some residual stenosis, and because of that, we decided to make second session with the orbital atherectomy. We did it, and after the second session and the second ballooning, let me see how much easier the balloon opened. You see, you will observe very slow inflation, and finally the indentation, the waist disappeared. You see, already the waist disappeared. And in this situation, we stayed almost 2 minutes inflation on 6 and after that 8 atmospheres. And we decided, like this morning I have commented, in case we have acceptable vascular result, not to implant stent, but to make a dracolutin balloon, let's say, inflation for better result in the future, to reduce the probability of restenosis. And in several minutes, you can see that the result is quite good. And during the final injections, of course, we checked the runoff, the distal runoff as well. So this is, in fact, the flow and the result after ballooning, this really critical multi-level stenosis. Of course, there was some spasm. Fortunately, the lady was quite hypertensive, so the nitro had double roll to control the pressure and to reduce the distal spasm. And after having this, I would say, acceptable result, we checked the distal flow, and finally we have checked also this is the second. Probably you saw some residual stenosis in the middle segment, and we repeated with higher speed exactly this in order to be also on the, let's say, side of the good result. Yeah, probably this is already the inflation with the dracolutin balloon. Yeah, this is the dracolutin balloon. And after the injections, it resulted that the lady has also restenosis of the edge of the iliac stent, and the peroneal artery that is observed here, definitely it was a spasm, because after the nitro the flow improved quite a lot, and also the stenosis of the peroneal decreased. And we saw, okay, probably this is angio. This is an angio showing, yeah, you see, yeah, there is a restenosis of the common femoral, and also the edge restenosis of but you can observe here the SFA is quite better. It's quite better, and we decided, in order to be on the safe side, and because the lady was really not very obedient with the therapy, we decided definitely not to implant stent in order not to increase the risk of thrombosis. And we treated these two tandem lesions before and after the distal edge of the stent with balloon inflation and dracolutin balloon again. This is the dracolutin balloon on the level of the iliac. And finally, we have injection of on the level of iliac and common femoral, and also distal. So this is previously, this is the dracolutin balloon on the iliofemoral level. This is the result on the iliac, and probably next will be SFA and tibial. So, more or less, this is the presentation for the orbital atherectomy. In case, probably, Rebecca, you probably have some experience. This is our first case. You can share with us your opinion and experience.
I have a question. Which kind of treatment do you give to this kind of patients? Because I listened that she has thrombus and multiple.
Yeah. We decided in this particular case to give her at least for 1 month anticoagulant and antiplatelet. Yeah, in this particular case. Otherwise, in case there is no special reason, we don't give this. But she definitely has a very big, let's say, trend for restenosis. In some cases, beyond the drug-eluting balloon, we are giving them rapamune orally for 3 months. We are giving low dose, 2 milligrams per day. 2 milligrams per day. There is an Argentine trial, ERASI 1 and ERASI 2. It was during the Cypher period, probably 20 years ago. And ERASI 1 and ERASI 2, they had quite encouraging result with oral rapamycin. And in patients with recurrent restenosis, we are giving rapamune, and we have good results. We have like a registry, local registry, and that is efficient.
Okay, we don't do it that. We this kind of patients, we do it sometimes 2 antiplatelets, you know, aspirin and clopidogrel, and of course we do with low dose of rivaroxaban, 2.2.
It's included in the guideline.
Yes, it's included in the guidelines. We follow the
COMPASS trial.
And of course, we put this kind of patients under atorvastatin, high dose.
Of course.
It's not the normal dose that 20 milligrams. No, we put sometimes 40 milligrams or maybe a little bit more.
80.
Yes.
Yeah.
Yes. But this kind of patient, that, like, she's a smoker and she's not going to quit smoking.
No.
Yes. Sometimes
she told me that she will not stop.
They prefer to lose a leg that stop smoking. So it's impressive, but I have patients like this.
Unfortunately.
Yeah, they're in Mexico, they smoke a lot. So in this kind of patients, you try to treat them and to do the best for them. But sometimes they are in 6 months, she's going to go again.
They do the best to do opposite.
We are doing
the best and they're doing worst.
Yes. But sometimes you realize that you get a lot of radiation with this kind of procedures, and they don't even take in account that you are... I said to them, I'm not going to do anything else because I cannot. Because next time I'm not going to do this because I got a lot of radiation, you are not following the instructions, and you cannot keep smoking, come on. So they don't, we have this kind of patients everywhere. Mexico is one of the countries that we have more diabetes thanks to Coca-Cola. Come on. And now Pepsi, but anyway, we have a lot of diabetes population. So we have a lot of patients with femoral and tibial arteries disease. So it's quite difficult sometimes to get good results for a long time. So you know that this kind of patients, they are going to come, and you are going to do something else, and you are going to find another way. If you cannot cross from anterograd, you are going to puncture the tibial. The tibial or
do you use the orbital also from below, from the tibial
No,
approach?
But to cross, yes.
Yeah, to cross, yes.
To cross.
Yeah.
Yes, because sometimes it's difficult to cross from up to down on the anterograd. So we to cross, to have a good idea where are we, first of all, we have to do the puncture, distal punctures.
Yeah, absolutely.
To do the crossover, yeah.
Yeah, like we did this morning. In fact, for we had a live case, and we punctured posterior tibial in order to cross predictably into the true lumen.
And that's very important to know where you can puncture the arteries. Where you going? If you cannot in the posterior tibial, you can do it on the pedal sometimes. And sometimes on the peroneal. I have been doing on the peroneal too. Yeah.
It's quite challenging.
Yes, quite challenging, but you have to many times you try to do the best for the patient. But this kind of patients are very difficult because you know they are going to survive in 6 months, 1 year, or less than that month with a new complication because there are chronic claudicants and they didn't take the medicine. And this kind of patient that has diabetes, I'm impressive that you use contrast. But sometimes we cannot use contrast, and we use a CO2.
CO2.
Yes. Yeah. And you know the image in CO2 they are not so clear like this.
No.
So sometimes it's more difficult.
Sometimes
each time.
we make in a combination. Once contrast, once CO2. In case we want really to see. We are going back to contrast, and
it's
but you're right.
Challenging.
It's a lengthy procedure, a lot of contrast, a lot of radiation.
Yes.
It's absolutely.
Yes. Congrats for the
thank you.
results, but I know she's going to come back.
Oh yeah.
Thank you.
Thank you.